This topic discusses pharmacokinetics and pharmacodynamics of anesthetics. We know there is no single anesthetic drug or even combination of anesthetic drug protocols that can be safely and routinely administered to all patients. In our effort to minimize the adverse effect associated with inherent risk of many anesthetics and adjuncts utilized, we depend on drug synergism by combining two or more drugs to reduce adverse effects compared to the situation where even a single agent can achieve the same degree of central nervous depression. And this practice has been carried out for many decades by clinicians, resulting in improved safety and efficiency in utilization of anesthetic drugs for smoother induction, stable maintenance, and uneventful recovery. A concept of combining two drugs were initially coined as neuroleptalgia, which is defined as a state of quiescence, altered awareness, and analgesia. Essentially, it is built on two main ingredients: neuroleptic agent and narcotic or opioid analgesic. Bruno is very worried about the cruciate repair surgery that he's about to undergo. And English Bulldog presents additional risk being a brachycephalic breed, particularly airway complications. So there are many neuroleptic agents that you can consider to give Bruno. We happen to choose asparagine and butorphanol. It's a kappa agonist and mu antagonist in an opioid class drug. So you can see Bruno is much more relaxed to go through the catheterization and general anesthesia. The neuroleptalgia also is exhibited here in this case with xylazine, butorphanol combined together, and you can see distinctive sign of the horse being relaxed, the head lowered, and the droopy eye. And this was achieved with alpha-2 agonist and opioid combined together. The next case received dexmedetomidine and morphine. As you can see, the degree of sedation compared to earlier case where asparagine and butorphanol was combined to induce premedication for reduce the stress and relieve anxiety. Obviously, the neuroleptalgia combination, depending on the choice and dose that you administer, it can result more profound degree of sedation. This pie chart represents the distribution of cardiac output at various body parts. Arbitrarily, we divide into 4 parts: vessel-rich group, VLG, muscle group, MG, fat group, FG, and VPG represents vessel-poor groups such as hair, bone, teeth. It's important to go over some basic physiological basis in relation to anesthetic drug effect. We all know anesthetics induce severe degree of cardiovascular depression, reduction in cardiac output as a result of decrease in heart rate, decrease of stroke volume, or both. Um, Also, mean arterial blood pressure is also governed by two variables, or expanded to be three variables. If you were to express cardiac output as heart rate times stroke volume, essentially, many anesthetics will reduce arterial blood pressure as a result of reduction in cardiac output. And you can relate the many drug effect, particularly inhalants, are notorious to reduce cardiac output, resulting in hypertension. And if you look at this, chart here, uh, the x-axis represents MEC multiples, 1 MEC, 1.5 times MEC, 2 times MEC, and the color histogram represents different anesthetics, mainly green representing halothane, orange representing isoflurane. What you can see here is that isoflurane maintains higher stroke volume at a given equipotent anesthetic dose compared to halothane. What doesn't change here is with the increase of anesthetic depth, they all reduce stroke volume in a dose-dependent manner. It's just that halothane is worse than isoflurane, presenting that isoflurane is more favorable choice whenever you administer these anesthetics in a given patient. Um, Obviously, the better the cardiac output is preserved, the more stable their um, cardiovascular health is. And that will translate into less morbidity or mortality. This graph represents similarly the x-axis denoting the anesthetic depth with MEC multiples, and y-axis now representing the changes of mean arterial blood pressure. And all four inhalants follow very similarly. Increasing anesthetic depth will result in greater reduction in arterial blood pressure. So in other words, the sparing or as little anesthetic administration as you can bear, of course, this assumes that there would be no awakening of a patient. So assuming that the patient is stable and not respond to surgical stimulation, the anesthetic depth should be maintained as light as possible. And that would translate again to improved patient safety. This dog is receiving thiopental, which is a barbiturate ultra short acting drug. And as you administer thiopental, you will see the patient try to patient becoming relaxed, getting more centrally depressed, with eyeball position indicating anesthetic depth. You can see the globe will try now move medioventrally, and as it reaches the peak effect, completely third eyelid hides the black glow part. So typically, this is the ideal anesthetic depth at the time of induction, but also during maintenance. So what factors govern the anesthetic effect in terms of depth or even the duration? Well, the drug dose, um, blood volume, cardiac output, the degree of ionization of a given molecule that you administer, the degree of protein binding, the rate of distribution of the anesthetic molecules at different um, speed into different body compartments, and also how they get metabolized and excreted by the uh, metabolic and excretory organs, mainly liver and kidney, will influence the duration and anesthetic depth. So we have some pharmacokinetic, pharmacological principles that we need to visit so that we could systematically um, understand various drugs because they all share a very similar path in terms of how they get metabolized and excreted, resulting in various drug effect. So pharmacokinetics essentially means what the body does to the drug. And this study regards to the following: how the drug will be um, distributed in the body, and the disposition of a drug um, includes the processes of ADME in abbreviation, or absorption, distribution, metabolism, and excretion. Pharmacokinetics essentially means it studies what the body does to the drug. And it's a study of the disposition of a drug. It has ADME as an acronym for how the drugs metabolize and excreted, with ADME standing for absorption, distribution, metabolism, and excretion. So in this spreadsheet, we can see on the first two columns representing the orally administered drug in a given rat population with a chronological order and the related drug concentration changes in the body. On the next two columns, we see the same changes of drug concentration per chronological order. In this case, the drug was administered intravenously. But what you can see here, the oral administration population, the drug concentration will actually increase in time 0.333 compared to the time point 0.166 hour. Whereas the intravenous drug group, the concentration will straightforward decline with no change or no surge as the time passes by. And this is represented in this graph with the concept of bioavailability. So essentially, the total amount of the drug in the systemic circulation to denote that intravenous route drug administration will have fraction to 100% or F equals 1, meaning that no drug will escape from the blood at the time that it is administered. But of course, when the drug is administered orally, the absorption of the drug through the gastrointestinal mucosal layer and portal vein and um, port, the hepatic path that will sometimes alter the drug shape and efficacy of the drug. And the result obviously will be less active drug amount available for the target receptors, and that will translate into less effective drug effect, meaning less efficacy or effectiveness. So the bioavailability describes the fraction of the drug amount in the circulation per the drug that is administered. And for oral route, it's obviously not going to be 100%. As you can see, the area under the curve, if you consider the 100% of IV route for the given drug, this would probably represent somewhere close to 50%. So some drugs will have a higher than that, or some drugs will have a lower than that. It really boils down to what would be the absorption, how readily they get absorbed, and the degree of metabolism and excretion that will be represented in the plasma concentration. This cartoon describes about distribution of the different drug at various stage of the body. Broadly, one compartment model is very simplified, that whole body is considered to be the target, and the drug gets metabolized and distributed homogeneously. Whereas two compartment model represent the central compartment will equilibrate with the peripheral compartment, and as the equilibration is established, the clinical effect will be represented. You are going to see the transfer of the drug concentration between the two compartments playing a big part in speed of the metabolism and elimination, and therefore the anesthetic duration as well as the anesthetic depth. This graph represents the change of the anesthetic drug called thiopentol. So when thiopentol is administered intravenously, as we saw in the canine patient earlier, we can see the drug concentration will rapidly change from 100% at the time of drug injected into the vascular compartment, and then that rapid decline will be followed by the steep rise of that thiopentol concentration in vessel-rich group. It's important to understand this vessel-rich group, i.e. the target organ, the brain, is the ultimately the representation of the clinical effect. So it's not surprising that you do not see the anesthetic induction immediately at the time of the drug injection. It's going to take a good 1 minute to fully exhibit its anesthetic effect. That's also represented by the steep decline of the drug concentration in the brain after 4 minutes, 3 to 4 minutes. And uh, by 8 minutes, the percentage of the drug remaining in the brain will be less than 20%. So at this point, the anesthetic recovery will be expected. So another aspect about the how the drug gets cleared from the target receptor, in this case, brain, is that distribution through the other compartment, in this case, largely muscle group, will be responsible for taking up the thiopental, and therefore the recovery uh, is present due to the fact that muscle group takes over the uh, saturation of the equilibration process of the drug concentration from concentration gradient in these different parts compartments of the body. Concept of volume of distribution in pharmacology is very important to recognize. It's a measure of the theoretical volume that a compound distributes into. And the formula is expressed as the dose divided by the concentration at at the time of the drug administration, and um, it represents obviously the higher the drug dose in relation to the concentration um, represented at the time of drug administered, the higher the volume of distribution value is. So the drug with a high volume of distribution will be so much more remain in the body and take longer for the drug to be cleared out of the body. Clearance represents the amount of plasma volume cleared of the drug per unit time. It's a measure of the elimination of a compound from the blood. There is a very useful interactive website. If you just click that or copy and paste that, you can play with the how the higher clearance will result in the process of the drug getting eliminated from the body. So I recommend go ahead and play with that interactive program. Very um, it'll be useful for you to understand better how the changes of clearance will result in drugs fate in the body. Um, Metabolism, it's really process of converting drugs to more soluble condition. They are predominantly carried out in the liver by hepatic enzymes. At times, other organs such as lungs could be responsible for metabolizing certain drugs. For example, propofol is believed to be also um, majorly metabolized in the lung. And this metabolism could be not just one step, but multiple steps for drugs that are not very soluble. The drugs becomes more soluble so that the excretory organ, mainly kidneys, will be able to eliminate these unwanted substances out of the body. Biliary excretion can also play in some drugs, as well as lungs also, or even skin through exhalation in the case of the lungs, and through perspiration in the case of the skin, being a step where they can excrete the body um, outside of the body of the drugs. In certain cases, lungs through exhalation, skin through perspiration, be responsible for drug excretion as well. So elimination half-life is the time it takes for the plasma concentration to be reduced by 50% and expressed as the T 1 over 2 equals 0.693 times volume of distribution divided by clearance. And elimination will be inversely related to clearance. So the higher the clearance, the shorter the half-life, and proportionally dependent on the volume of distribution. So higher the volume of distribution, the longer the half-life becomes. And I recommend you also play with interactive website listed there, um, as you can change the values of volume of distribution and clearance, how that will affect the uh, half-life. So this spreadsheet will describe the multiples of half-life and the effect of the drug remaining in the body. So at the time the drug is given, the drug left in the body will be 100%. Or the drug ratio of the drug left becomes 1. After first half-life, 1 times T, 1 over 2. The drug left in the body will be 50%. And the ratio of the drug, obviously, half. Let's say that was 1 gram to begin with. Now you have a half gram. After 2 half-life pass, the amount of the drug left now would be 25%. Because remember now that 50% now moving down to 25%. And that half gram now becomes a quarter gram. A quarter gram is left. And then you move down this, and then what boils down to here is by 3 times of half-life. So let's say the elimination half-life of a given drug was half an hour, 30 minutes. So by 3 times of that half-life, 30 minutes times 3, that's 90 minutes or an hour and a half. I would say 87%, almost 87% of the drugs, because even by 2 times of the half-life, 75% of the drug will get cleared. In order for you to keep up with this redosing regimen, you need to understand about the fact that half-life times 3 times will almost mean that there will be literally very little drug left. It's going to take that much more of an effort for you to keep up with stable drug concentration in the body. What you're looking at is the bottle of the propofol, very commonly used anesthetic induction agent both in human and veterinary market. It's a phenolic compound. You see, it's different to barbiturate, different to phencyclidine derivative dissociative drugs such as ketamine. It's very distinctive in color. It's just milky in color is because it contains soybean oil, egg lecithin, and glycerol because they do not dissolve in water well. There are certain formulations where they have antibacterial ingredient such as benzocaine. There is no antibacterial ingredient present in the formulation. It is not permitted to use after 8 hours of opening and withdrawing the drug from the vial. Obviously, Abbott Propofol 28 means 28 days because of benzocaine that will prevent the bacterial growth. So with the exception of that, use the non-antibacterial formulation beyond 8 hours. Etomidate is another anesthetic induction agent that veterinarians could use. It's not very commonly used. It is much more expensive than other alternatives, including propofol, ketamine, and alfoxolone. The drug is an imidazole derivative. It is used in a situation where the patient carries some underlying cardiovascular diseases, as this terminate maintain the cardiac function better than the other alternative. That this drug is recommended to be more preferable in cardiovascularly compromised patients. The dose in men obviously much lower than the dose in dogs and cats, presenting some species differences there to the susceptibility to the drug. A single intravenous dose is reported to suppress adrenal steroidogenesis in dogs and cats for several hours, clinically believed to be insignificant. Just like other injectable drugs, including thiopental and propofol. The recovery is through redistribution to the muscle group, but also this drug is undergoes rapid hepatic metabolism, therefore repeated dosing not resulting in cumulative effect or prolonged recovery. Some undesirable adverse effect is seen with the Tomidate, such as retching, myoclonus, sneezing, and it is recommended good muscle relaxant, midazolam or diazepam precedes. This is a human data on two main induction agents, thiopental and propofol. As you can see, thiopental has 3 times longer elimination half-life compared to propofol, and that is because of lower clearance. At least lower volume of distribution makes up therefore clearance rate tenth of the full. Cataset or ketamine, telazole is a combination of tilatamine and gelazole. These drugs are classed as dissociative anesthetic induction agents, very unique in that they preserve the laryngeal, pharyngeal, palpebral corneal swallowing reflex. In fact, they appear to be very awake with the eyes open. They would induce increased muscle tone, and salivation reclamation is also present. And they are very useful and superior to provide somatic analgesia, and both intramuscularly and intravenously will induce the effective anesthetic depth to allow endotracheal intubation. Would think this cat is awake if you are not familiar with how the dissociative anesthetic produces. One cue or hint here is that distinctive protrusion of third eyelid covering the partial portion of the globe. The dog is more susceptible to have adverse effect associated with the dissociative anesthetic drug. In this case, the image on the left shows the excessive salivation, and the image on the right also demonstrating degree of hallucination associated with ketamine. And it is noted the species difference between dogs and cats has been pointed to has pointing to the difference between these two species, how they handle the drug. So obviously, the cat has much faster and smoother recovery from ketamine. We know that has largely due to their ability to excrete ketamine through the renal clearance. And on the other hand, dogs will exhibit slow and stormy recovery with the head shaking, typical Stevie Wonder head bobbing, the salivating, muscle rigidity, vocalization, even defecation and urination associated with the dissociative anesthetic drug. So it is important that we recognize this potential species difference to the same drug and guide us in constructing the anesthetic regimen based on this. One thing about phencyclidine drugs' popularity in the cat is the ability of these drugs to be administered intramuscularly in the cat and being able to induce predictable degree of central nervous depression. As you can see here, ketamine 10 milligram per kilogram combined with diazepam 0.2 milligram per kilogram intramuscularly administered, much better muscle relaxation compared to the ketamine asparmazine combination. As you can see, the cat exhibit much more distinctive adverse effect associated with dissociative drugs hyperrigidity. Telazol, as I explained earlier, it's a combination of tilatamine and zolazepam. Tilatamine is essentially same as ketamine, and zolazepam is same as diazepam. It's a benzodiazepine class drug. So the drug is provided in a powder form, and you constitute that with distilled water, or you may even use drugs such as butorphanol, dexmedetomidine to reconstitute that. The whole idea of constituting those telazol with those drugs is to increase the potency of the final cocktail, and obviously it will require smaller volume and smaller dose, achieve still the same effectiveness of anesthetic induction and maintenance. So the plasma half-life of zolazepam is 1 hour, and tilatamine is 1.2 hours in the dog. And as you can see, the plasma half-life of zolazepam is 4.5 hours, and tilatamine is 2.5 hours for same value in a cat. So you can see how the faster clearance of the benzodiazepine component of this in a dog will result in emergence delirium and hallucination, whereas in a cat, the clearance of zolazepam is much slower, and therefore the relaxing and sedating effect of benzodiazepine will outlast the phencyclidine drug effect in a cat. So that explains the difference of dogs and cats in terms of how telazol will result in a different degree of anesthetic recovery. So I have this 5 different general anesthetic procedures listed here. So you can totally depend on intramuscular route of drugs to induce and maintain anesthesia, or a drug or combination of drugs administered intravenously to induce and maintain anesthesia, or the induction of anesthesia induced with intravenous anesthetic drug, and then the maintenance will be carried out by inhalant agents, notably sevoflurane and isoflurane being the most popular in veterinary practice nowadays, or the anesthesia carried out by intravenous anesthetic through continuous rate of or CRI, or anesthetic induction and maintenance exclusively by inhalant. So some of the chart here will guide us what to expect of these different techniques. So here in the x-axis representing the time, y-axis representing the degree of anesthetic depth. So as you can see, intramuscular injection of anesthetic drug or combination of anesthetic drugs will result in about 10 to 15 minutes of wait time for us to really reach to the optimal anesthesia portion of it, and then 15 to 30 minutes of duration, and then they return to the recovery phase. So it obviously will tell us you are expected to wait at least 15 minutes with a surgical time, if you were to perform a surgery, allowing about 15 minutes, and then the patient will start to wake up. In this graph, intravenous induction with an ultra short acting agent to effect, we see that anesthesia is achieved within minutes, and then it lasts approximately 5 to 10 minutes. So the patient would only remain very short period of time of surgical depth, and then they will wake up. Characteristic of intravenous anesthetic induction and maintenance. In this case, we wanted to redose to extend the intravenous induction agents anesthetic effect that would only last 10 minutes. So as the patient to recover from that single induction agent administration, The second injection, smaller, in this case, usually one third, will deepen anesthetic depth, but then they will start you to wake up within minutes as well. So you keep giving the small bolus, third time, fourth time, fifth time, sixth time, and so on to extend the surgical depth. And then obviously when you stop the redosing, they will now return to the recovery. That's a one way to extend duration of anesthesia if you were to use ultra short acting induction agent intravenously. Instead of keep redosing in a small bolus, you can also substitute the continuous rate of infusion drug administration. So it will have an advantage over the small bolus repeated dose with a less peak and trough changes of the anesthetic depth. And as you can see, infusion rate compared to this yo-yo of the anesthetic depth is more stable and plain. And if the patient were to wake up, then increase the infusion rate to adjust the depth. And that obviously is much faster with this approach compared to the small bolus. The other we described earlier was exclusively depending on the inhalational drugs to induce and maintain. And that's typically reserved for a very difficult fractious cat that you would have hard time even touch the cat. And see various form of induction chamber are available. You administer volatile anesthetics that way, or at times for various reasons you may induce canine patient with volatile anesthetics through face mask. Just like intramuscular drug administration, you would anticipate the slowing transition of the anesthetic depth. So it's taking, compared to a minute or 2 minutes of intravenous anesthetic, taking the clinical anesthetic stabilization, it's going to take 5 to 10 minutes, much longer time. And then you maintain the anesthesia throughout however long the procedure dictates. The drawback about this technique, other than the slower onset of the anesthetic induction compared to intravenously administered anesthetic induction technique, is potential exposure of that inhalant anesthetic to the operator. However careful you carry out those process, you are going to have a spillage of the inhalant, and that's obviously a health risk to you and the bystanders. So this technique is generally not recommended. I would say the best approach is this: induce with intravenous anesthetic drugs, and then intubate the patient, transition the patient anesthetic depth on inhalants, whether that's isoflurane or sevoflurane. Of course, at times you may run the anesthetic depth light, but fortunately, anesthetic equilibration and stabilization is very rapid with the modern inhalants such as isoflurane. Sevoflurane is even faster than isoflurane, and however long you maintain anesthesia, the recovery would be within 10 to 15 minutes from inhalant anesthetic. That's typically how the anesthetic drugs are administered in clinical situation in dogs and cats. Another important concept in pharmacological principles is pharmacodynamics. It's drug actions at receptor sites, the physiological, chemical, behavioral effects produced by these actions. So you can see endogenous and exogenous transmitter and drug ligand bound to the receptor and altering the change of ionic flux, and then therefore nerve transmission and resulting in anesthetic effect. So pharmacodynamics are best explained by looking at the drug's dose response relationship or dose response curve. So the x-axis represents the logarithmic scale of the dose changes, y-axis representing the clinical effect or drug effect. Obviously, the smaller dose as increase, the drug effect will increase as well. So it'll be a straight line, positive correlation between drug dose and response. A best example of looking at the dose response curve is for opioid drugs classes. So, opioid receptors in brain and spinal dorsal horn will be responsible for the clinical effect, mainly analgesia. That is what we are after for prescribing opioid drugs to our patient. There are three receptors that are known as a mu, kappa, and delta, and mu is subdivided into mu1 and mu2. And analgesia is obviously the principal goal of prescribing opioids to our patient. There are some added benefit of some patients become more sedate with the opioids. Actually, it's interesting also in humans and dogs, mostly opioids are depressing, whereas cat, horses, and pigs, we will see the stimulation from the opioid. So definitely the species variation is a good contrast how opioids will either induce depression or stimulate. Four subclasses of opioids are full agonist, partial agonist, antagonist, mixed agonist, and antagonist. To better illustrate the relationship between these subclasses, we can take a look of, again, dose response curve. On the blue slope, in reference to the full agonist, and the purple slope is still full agonist, knowing that it reaches the maximum 100% effect, drug effect. It just requires greater amount compared to the drug represented in blue graph, blue line. The one on the bottom here, partial agonist, represented in red, is just the example of drug that can never reach the maximum effect despite how much amount that you administer. So they can only reach that sub-maximal dose, in this case, roughly 50%. So in real life, for opioid, the morphine is the gold standard that all other opioids are compared against. I would say the purple is morphine, hydromorphone is the blue. Hydromorphone is about 10 times more potent than morphine. And the red one would be drugs like buprenorphine or butorphanol. They are categorized as partial agonist or mixed agonist antagonist. The drug class antagonist obviously has absolutely no effect on the receptor. It just makes the drug lose its effectiveness when you reverse the drug by administering antagonists. A very interesting shape of the drug dose response curve is a bell-shaped dose response curve. This is we are puzzled by because generally most drugs fall into this dose response curve shape. They peak at the maximum effect, and then or they peak at the sub-maximal effect, but then increasing those will just do not change the drug effect. Increase of drug dose in this scenario means they will lose the effect of the drug. So the greater amount of the drug that you administer, the less effective they become. That's why a drug that will exhibit this dose response curve should be very carefully dosed, because the dose that you will exceed the clinically useful drug dose, and they become useless. And one thing that I will tell you is the buprenorphine follows this dose response curve. So greater buprenorphine drug dose could sometimes have absolutely no benefit to the patient, as you have given too much of the drug dose, buprenorphine, and therefore they were actually. Just as a side, as an ancillary information, additional information here, I would say any drug that you use on a daily basis would have a very useful information from the manufacturer themselves. So, for example, now alfoxan, a trade name for alfoxalone, it's a neurosteroid intravenous injectable anesthetic that is licensed for dogs and cats in many parts of the world, as well as in the USA. It's not a completely new drug, although new formulation. In the old days, alfoxalone used to be supplied in a different vehicle or solvent, for EL, which is a highly um, allergic to, unfortunately, our patients across the board, across species. It just uh, the allergic reaction was so severe enough in some patient they die of the anaphylactic shock. So uh, the older formulation of Foxalon was taken off the market for quite some time until a company called Durax based in Australia reintroduced the same molecule, but in this time solubilized in much safer solvent cyclodex. So it says cyclodextrin is inert, doesn't cause histamine release. It's eliminated and changed. And the information of the drug molecule in the package insert, such as the volume of distribution, elimination half-life, and clearance in a dog and cat, obviously will provide us the guidance to expect how long the clinical effect will be present after drug administration. So in this case, see the cat being much slower to eliminate, clear, the anesthetic effect will be longer. This also explains about the different drug alfoxalone, how they are administered into the central compartment and then eventually they get eliminated by three compartment model. So some drugs will follow a single compartment or one compartment model, or two compartment or three compartment, depending on how they are handled by the metabolic and excretory organs. So something to consider as you encounter animals with a deficiency in liver functions or renal functions, how you would dose or adjust the anesthetic dose, and also anticipate the duration of anesthetic effect based on this information. So the drug package insert or manufacturer information also is useful to begin with how long we should anticipate the initial induction dose will last, and dogs becoming twice faster in clearing the drugs, and therefore lasting only half of the duration that will have on cats, which is 25 minutes. The blood pressure and respiration rate is well maintained. So the drug is, again, very successful in anesthetic induction purposes. The only thing that holds this drug to replace propofol is the pricing point. So about 5 to 10 times more expensive than propofol. And I believe when the price is reduced, um, it'll be just a matter of time um, that this will be as popular as propofol, if not more. Uh, we just can recall the time when propofol used to be 10 times more expensive than thiopental, and that was prohibiting the replacing of thiopental with propofol at that time. But as the price point um, was no longer of a concern, and propofol became so much cheaper as they lost the patent right, and many other competing manufacturers came um, into the market. Uh, the propofol pretty much replaced the thiopental at that point. So a similar fate will await for alfoxylon, and um, the pricing of this molecule will be much more affordable. The caveat for use here is describing how you should be careful in uh, dosing this drug or administering this drug. You should administer very slowly over 60 seconds to prevent apnea. And this is actually very similar to propofol as well. And the slow titration, so it minimizes the occurrence of apnea. Um, Obviously, as a single induction agent, uh, it provides a very useful purpose for that. Once the animal recovers from that, there will be no remaining analgesia. So, if you were to operate on a patient, prescribing analgesia would be essential. And the drug is rapidly cleared or eliminated from the body. And at times, a stormy recovery is a potential drawback this use. And pre-medication that will mask those potential recovery hallucination or excitement would be advisable. And the drug obviously holds many advantages over propofol in terms of that the drug can be administered intramuscularly as well to be useful. You can really get the general anesthesia with the intramuscular propofol. So some definite advantage of Foxalon over propofol. So I think that's all I have for this presentation. And I hope that this presentation discussed some useful concept for you to understand and apply in anesthetic practice for improved safety and efficiency. If you have any questions, please feel free to send me an email llyon@westernu.edu. Be happy to answer any questions. Or if you were to ask some Q&A and invite me in a Zoom session, I'll be happy to do so.